Hello everyone, and I hope everybody is doing perfectly fine. Today we'll be discussing an entity that is Calcinosis cutis. So as the name suggests, you can correlate that there is something related to calcium deposits, correct? So I'll be discussing what this entity is, and we reviewed few cases related to calcinosis cutis in various sites, and also we made an attempt to study their pathogenesis, what is the basic mechanism behind this entity in detailed clinical and radiological evaluation along with our cytological evaluation. So this calcinosis cutis, first important thing, it is benign lesion. It is not malignant. So nothing to worry much about it. And this is uncommon, not usually seen. And how we described it? We describe it as deposition of calcium in skin. It is cutis, as the name suggests, calcinosis cutis है, ठीक है? So calcium can be deposited in your skin or it can be deposited in subcutaneous layers. Clinically, how it will be? It is like your firm to hard, solitary, painless, multiple nodules can be seen. And usually in these benign lesions, what we see is the basic जो body का calcium और phosphate metabolism है, that is not altered. It can be due to tissue damage. So local tissue damage, that is releasing your calcium, and then calcium is getting deposited. Some alteration can be there in the metabolism, or idiopathic factors can be there. Usually there is no alteration in calcium and phosphate metabolism. And few cases they have also described that उस जगह पे जहाँ अभी suppose हमें calcinosis cutis मिल रहा है, एक lesion मिल रहा है patient में किसी site पे, so few paper which have been published, they said that this presence of dystrophic calcification. We know calcification is of basically two type, dystrophic and metastatic calcification. So they said that presence of dystrophic calcification in pre-existing lesion, मतलब patient को पहले से कुछ था, like these entities, epidermal cyst, calcification in eccrine sweat ducts, then degenerated muscles or calcified nodules, and there these dystrophic calcification is getting deposited. So these lesions, जो calcinosis cutis है, it can be seen ubiquitously anywhere in the body. However, common locations जो होती हैं इसकी, those are your scrotum, head and neck region, neck, back, thigh, arms, and axilla. So what we did, we reviewed our data and we followed like 12 cases of calcinosis cutis over a period of 2 years. And age of the patient were extreme age में हो सकता है ये, like 20 to 60. Our age group were 12 to 60 years. Median age हमारे study में it was 35 years, and there was a male preponderance. Male-female ratio to be 2.5:1. And how the patient will present to you with calcinosis cutis. Normally malignant lesion क्या होता है? They evolve very fast and the deterioration and increase in size of the lesion is very fast. ठीक है, वो spread करता है. These patients will come with you with chief complaints of slowly growing, painless, solitary to form hard, variably sized nodules. And these swellings were mobile as well as fixed depending on the different cases. And size, it ranged from 0.8 centimeter to 4 centimeter in our study. Scrotum, out of, we studied 12 cases of calcinosis cutis. 5 calcinosis cutis cases were seen in scrotum. Other regions which were noted in our study were neck, back of back, ear lobule, cheek, lower chest, arm, thigh region with 1 case each. So all cases had unilateral presentation in our study. And 7 cases out of these 12 I am saying, 7 cases showed solitary nodule except for 5 of scrotal calcinosis. Scrotal calcinosis typically, usually you will see is multiple subcutaneous nodule all over the scrotal sac region. And in all cases, our patient gave a long history of these evolving lesions, ranging from approximately 1 year to 14 years. If you can drag some patients, they do come to OPD as early as possible, so they will give you a long-standing history कि बहुत पहले से हमें ये swelling है, ये गांठ है हमारे शरीर में. So on examination, what you will see, these swellings are formed to hard in majority of cases. सो प्रोविजनल डायग्नोसिस क्लिनिकली जब हम देखते हैं इन केसेस को कि कोई स्वेलिंग लेके आर्म पे, थाई पे, बैक पे, लेग्स पे, स्क्रोटम पे, सो व्हाट प्रोविजनल डायग्नोसिस कैन बी डिफरेंट लाइक एपिडर्मल सिस्ट, कैल्सिफाइड नोड्यूल. सो क्लिनिकल डायग्नोसिस भी हो सकती है, पोस्ट ट्रॉमेटिक लीजन हो सकता है, सॉफ्ट टिश्यू लीजन हो सकता है, न्यूरोफाइब्रोमा, ट्यूमर कैल्सिनोसिस एटसेट्रा. Radiological findings were there. Out of 12, 5 cases we had radiological finding जिसमें 2 का अल्ट्रासाउंड हुआ था और 3 पेशेंट की एक्सरे रिपोर्ट थी हमारे पास. तो जो अल्ट्रासाउंड 2 केसेस में हुए थे उन्होंने हमें रिपोर्ट दी थी that showed presence of discrete and aggregated echogenic nodule in subcutaneous region of scrotum with no involvement of deeper structure. X-ray was reported as calcified nodule in 3 of other cases, but we need to verify it. So these are the clinical picture I am showing you. So these scrotal skin is showing you multiple nodule formed to hard nodule. So FNAC material with chalky white material aspirate हुआ था when FNA was done. And this second image is your right upper thigh में एक bluish brown to bluish discoloration nodule था formed to hard. And patient presented with right left cheek पे भी एक swelling थी. So this was all clinical picture I am showing you. So we did FNAC in all these 12 cases. Like when we put the needle, there is a gritty sensation in all these cases. There is a, when we do needling in all these cases, you see gritty sensation. And it is very difficult to pass the needle through, and it can get blocked also with a thick material if we aspirate it. So FNA will yield you chalky white paste-like material, and with those material, that material, cheesy white chalky white paste material, will make smear, and then we stain it with pap stain and giemsa stain, and we review it under microscope. And smear, what it will do, it will show smear जो हमने देखा, examine किया, so it will show different cases of similar morphology. 12 cases में हमें similar morphology मिली थी. What we got, जो typical है calcification का, presence of your bluish amorphous granular material, crystalline structure confirming the diagnosis of calcium deposits. There was no evidence of epithelial cells in any of these cases. We didn't get. Few cases showed presence of scattered histiocytes, lymphoid cells, multinucleated giant cells, depending on the reaction. So this is our cytological image. क्या देख रहे हो आप इसमें? You see bluish amorphous granular material which is suggestive of calcinosis, calcium material. And section this A and B is showing the same. And here ये cyto की images है A and this is B. 20x है, this is 40x. Enlarged view है. You are seeing this amorphous granular material. And we did biopsy. एक केस में हमें biopsy मिली है. So this is a calcified. These are the marrow elements and this is bluish discolored. You are see calcified materials है ये सारे enclosed in the marrow space. So based on this extensive calcium deposit in all our cases, and along with calcium deposits, many cases showed presence of your lymphocytes, macrophage, multinucleated giant cells, as I mentioned earlier. And out of this 12 cases, 6 cases में हमारे पास history थी what the management was done. So surgical excision was done in 6 of these 12 cases. And surgical excision के बाद हमने 6 cases में histoproven करा. That is hematoxin eosin stain we do it for biopsy section cases. The section examined showed extensive globular deposits of basophilic calcified material. So this is a summary of all our 12 cases. So देखो male में usually this it was scrotum है, male में we got calcinosis cutis in upper cheek, neck region पे, female we got in thigh and back. So clinical diagnosis you can see, किसी में epidermal cyst बना है, किसी में skin and neck cell tumor बने हैं. So cytological diagnosis is in all cases it is calcinosis cutis. So see how efficient FNA diagnosis is in all these cases. We need not do the biopsy also. So this is another one. The female में left lower chest है, male में scrotum. Ear lobule also we got, arm also we got. So see I am pointing towards the clinical diagnosis. So variation है जो हमने differential diagnosis पढ़ा ना कि कोई benign tissue benign cyst दे देगा, neurofibroma, calcinosis, epidermal cyst. So we verify it on cytology to be calcinosis cutis in all 12 cases. So this is, as I told you, deposition of calcium है skin में subcutaneous region में. In 1855, this entity was for the first time it was described by Virchow, and it is usually found in scrotum and head and neck. That also we found, but it is ubiquitously present throughout body. You can get it. And idiopathic scrotal calcinosis was first described by Lewinsky in 1883. It is a benign rare type of calcinosis cutis, independently involving the scrotal region. Sorry. So the common age group presenting this entity is 20 to 40 years. However, extreme of age can be also noted. हमारे case में भी, हमारे series में भी we had a case in 12-year-old child. So it results from idiopathic tissue damage हो सकता है, abnormal calcium metabolisms in few cases. And this calcinosis, as we know, हमने देखा था dystrophic, metastatic. In dystrophic, there is no calcium derangement. In metastatic calcification, we get abnormal calcium metabolism. There is hypercalcemia. Then there is iatrogenic induced hoga instrument and idiopathic. But however, there is no exact consensus about what is the pathogenesis of calcinosis cutis. Few studies they have attempted to link with dystrophic calcification, like कि पहले से कोई लीजन था उसमें डैमेज हो रहा है तो उससे कैल्शियम रिलीज हो रहा है, डिस्ट्रोफिक कैल्सिफिकेशन, तो लोकली डाइंग डेड डाइंग टिश्यू में कैल्शियम सॉल्ट्स आर गेटिंग डिपॉजिटेड. सो दे ट्राइड कि पहले से कोई सिस्टिक लीजन, अक्राइन डक्ट लीजन है, अक्राइन एपिथेलियल सिस्ट, degenerated dartus muscle in scrotal calcinosis. So they are linking it to dystrophic calcification. But and few studies they have associated their linkage with connective tissue disorders also, like your SLE, scleroderma, dermatomyositis, and also with previous trauma, inflammation, impacted foreign body material landing up in degeneration and resulting in formation of these calcium deposits. In few cases they have shown that presence in previous epidermal inclusion cyst with granulomatous reaction हुआ, cyst rupture करा, calcium salt बाहर आया, किसी में distraction of the keratinous epithelial lining, and consequently इसलिए अगर जो keratin lining का distraction हो रहा है तो इसलिए कोई viable epithelial tissue नहीं मिलते हैं in calcified lesions. An important point is we need to distinguish this entity, that is calcinosis cutis, from your calcified epidermal cyst, calcified fibrous pseudotumor, pilometricoma, tuberculosis, etc. So these entities, they can be diagnosed by your presence of their lining epithelial remnants and other specific features. So to conclude, histopathology, as I said, we did not require in all our 12 cases. However, surgery was done in 6 cases. We got the biopsy. So, but 12 cases में हमने FNA करा. That was all FNA proven calcinosis cutis. So it is not required. Histopath is not required to give you a definitive diagnosis of calcinosis cutis. Radiology in conjunction with cytology should be sufficient to make a correct diagnosis. So as we know, FNA is a very simple, non-invasive, fast technique which will help us in identifying these calcific nodules, and maybe because of some cosmetic region or structure deformity. So these can be managed by simple excision of the localized lesion. So thank you so much for your patient hearing. Kindly like, subscribe and share my YouTube channel Patho with MK. So kindly wait for few more upcoming lectures. Thank you so much.